That's how the patient was referred to our unit, and that is the one which is showed there, the aneurysm aorta, prominent aorta. And then once it was seen, next investigation is you do aortography called a CT of the contrast CT it is called. We inject dye into the patient and you can see it's dilated. This is the huge aneurysm of the whole lower part of the aorta. In this area is the vocal cord. So this was pressing on the vocal cord. The reason for hoarseness of voice was an aneurysm, not any problem with the throat. And now, when he came here, he was complaining about breathlessness. So when anybody complaining of breathlessness at his age, 66 years, we always have to do an echo, and we found out that the heart function was only 40%. Echocardiogram shows. So there should be some reason for that. Then we did straight away did a coronary angiogram and found that the main artery supplying the heart, the right side and the left side, both had significant blockage, which is responsible for his breathlessness. So the patient came with hoarseness of voice, which is caused by the aneurysm, and breathlessness is due to triple vessel coronary artery disease. Both were missed, and the patient went to different people, and we had to diagnose these two. And once we diagnosed the problem, then the doing both together is very risky. We cannot do bypass first, because if you do a bypass first, when during the operation, sometimes this aneurysm can rupture. One of the fatal problem of aortic aneurysm is rupture and sudden death if not treated on time. So at the same time, if you operate for the aneurysm, patient can have a heart attack, and he can sometimes die also during the procedure. So then we discussed among our team, and then we talked to the patient what is the best, because doing both together is very risky. So we thought we will go through the lesser risk procedure, because if you do the operation, bypass surgery with using heart-lung machine, again sometimes this is the aorta ruptures, means the blood coming out of the aorta, you can die suddenly. Then one of the problem is in bypass surgery, when the patient is very sick, when the heart function is very poor, sometimes they can have low blood pressure, needing what is called intra-aortic balloon support. So that cannot be put in this patient because of the aneurysm. Usually we place it in the aorta. So if during bypass surgery, if any complication occurs, it is very difficult to save him. A life-saving support cannot be given to him. So first, if you do the aorta, like what I said, sometimes blood pressure droppage can produce a myocardial heart attack during the procedure. Sometimes it can produce cardiac arrest also, which could be fatal. So what we told the patient was, these are the problems involved, but we decided that a bypass surgery without stopping the heart, that is on a beating heart, bypass surgery is safest for him first. Then we will control his blood pressure and wait for at least about a month, so that he recovers out of it, and do the aortic aneurysm surgery. So this is the, it will work, the video work. I'll press once more. Yeah. So we did the bypass surgery on a beating heart. That is the video what you are saying, opening the heart, the breastbone, and then we are taking the artery from behind. It's called the internal mammary artery. So this time the blood pressure is monitored properly, so that it doesn't go high or it should not go down, because all these can alter the hemodynamics of the patient, sometimes can produce cardiac arrest. All these are possible in this patient. So we are opening the artery and stitching. That artery was blocked about almost 90% blockage. Usually if the artery is functioning normally, the blood will hit the roof. It will be tremendous flow. You can see the blood flow is very less. Now we are stitching that is a shunt we call. When we do the operation, the native flow, the blood flow is maintained through this shunt. There's just got a hole in the middle. So while we take stitches, blood is flowing naturally through this artery so that the heart function is preserved during the procedure. That is the major bypass we are doing. That is an artery taken behind the breastbone, and that is going to be connected to the, it's called the left anterior descending artery. That is the main artery which supplies blood to the heart. This artery is called the widowmaker. Usually, olden days in the pathology books they call it, because usually heart attack occurs in a male, and if it gets blocked, you die. That is called, it's called the left anterior descending artery. The lady is called the widowmaker. It really is, because in a massive attack, occlusion of the lady can kill you straight away. So people die of a sudden heart attack when that artery, 3 out of 10 patients die if that artery is blocked. So this is the second bypass we are doing with the vein taken from the leg. That's all. Okay, good. We have 3 bypasses actually. Now, after that, this is the second procedure. That for this, we didn't want to open the chest and do an open operation. So this is done by our interventional radiologist, Dr. Murali is here. He is the main person who does this stenting. So we work as a big team. We have got our physicians, then interventional radiologists, then our own team, plus our intensivist, anesthetist, because you need a big team to look after these type of patients. When one patient made, as you see, different procedures. So each person who is specialized in will do this procedure. This is you make a small hole in the groin, and then through that the stent is introduced, and that is how that area where you saw in the X-ray. This is a metal stent with a cloth cover which covers that aneurysm and prevent it from rupturing. You can see that being live it is. That is the stent being delivered inside. So the take-home message in this patient is, the important thing is to diagnose, the clinical diagnosis. When we got the patient itself, we diagnosed everything. Because of breathlessness, the heart disease was not diagnosed anywhere. We are referred to me for an aneurysm case with the breathlessness as the present symptom. But basic cause of breathlessness was a serious heart problem with multiple blocks and impairment of the contractility of the heart, that the muscle of the heart was weak, and then we have to decide what is to be done. Very important. If you take a wrong decision, suppose I do both the procedures together, sometimes the patient will not have survived that. So timely diagnosis and decision making is the most important thing, when to do what. So now you see hoarseness of voice, presented hoarseness of voice and breathlessness. Both was fatal thing. If it was not diagnosed properly, I don't know how long, because the main artery involvement he could have developed, he was planning to go to US. So probably he would have had a problem during traveling or after going there, because if he continued the treatment of breathlessness. So a simple chest X-ray examination has helped this patient. So not all breathing difficulties are lung diseases. So simple, that chest pain, pressure, heaviness or discomfort will be there normally in all heart diseases, but it was not diagnosed properly. Sometimes there will be dizziness or lightheadedness and exhaustion, extreme exhaustion on exercise. So it points down to people who are at high risk. The risk, what I mean is elderly people over the age of 55, those who are diabetes, those who have family history of heart attack, and those who are high blood pressure. A regular health checkup can pick up a hidden disease which could be fatal sometimes. It's like a X-ray, echocardiography and blood examination, and if necessary a CT scan definitely will help in picking up patients who have silent problem which can be fatal. That is why sometimes we feel that so and so absolutely normal, suddenly fell down and had a heart attack. Sometimes aneurysms also are not diagnosed. People died of rupture. Somebody dies at home, somebody dies at work. If the PA postmortem is not, and we don't know. So important thing is every new governor of our country is recovering because even the
and the nephrology team at SIMS. Our whole story started with coming with Mukesh was suffering from restlessness more than 5 months ago, around October of last year, and we just attributed it to his lungs, and he had some varicose veins, so he had swelling in his feet. And so we came here and we visited Dr. Sridharan, R. Sridharan, a pulmonologist, and Dr. Sridharan did a PFT for him, and his function was low, so he said, let's take a chest X-ray. And for the chest X-ray, the whole story. CT scan, we went to a cardiologist, and we got a color Doppler done, for which we had to wait because of his kidney issue. He's a CKD patient too. And then he brought us to SIMS. When we came to SIMS, we were going to just a stent for him for his descending thoracic aneurysm. But then when his ejection fraction was low, so we thought Dr. Sarbaji suggested we do an angiogram here. We did the angiogram and we found blockages in his heart. Entire team, we had the stent placement done on August 1st. And this is our first 7 days after. Yeah, and taken very good care, and it was miraculous the way his entire, how he could walk about, talk, function, right? And the timely intervention by Dr. Raj, the cardiology team, and entire SIMS team. That's all I have.
ENT டாக்டர் பார்க்க போயிருந்தாங்க. ENT டாக்டர்கிட்ட ஒரு 2 months ட்ரீட்மெண்ட் நடந்துட்டே இருந்துச்சு. அதோட சேர்த்து அவருக்கு மூச்சு வாங்குற தன்மை இருந்துச்சு. ஸோ இந்த மூச்சு வாங்குறதும் இந்த குரல் மாற்றம் ஒரே இதை நினைச்சு ENT டாக்டரை கொஞ்ச நாள் பார்த்துட்டு இருந்தாங்க. அதுக்கப்புறம் என்னன்னா தென் தே வென்ட் டு ஒரு பல்மனாலஜி டாக்டர் போனாங்க. பல்மனாலஜி டாக்டர் ஆக்சுவலாக ப்ரீதிங் டிஃபிகல்ட்டின்னு சொன்னனால மூச்சு தரத்தில் இருக்கிறனால ஒரு எக்ஸ்ரே எடுத்து பார்த்தாங்க. அந்த எக்ஸ்ரேல தான் நம்ம ப்ரெசன்டேஷனில் சார் காமிச்சாங்கல்ல, ஸோ அதில் மாதிரி அந்த பெருந்தமணி கொஞ்சம் வீக்கம் தெரிஞ்சிச்சு. ஸோ அதுக்கப்புறம் தான் சிடி ஸ்கேன் பார்த்ததில் பார்த்தா அந்த பெருந்தமணி அயோட்டா அப்படின்னு சொல்றது வந்து வீக்கமாக இருந்துச்சு. நார்மல் சைஸோட கிட்டத்தட்ட 2 times 3 times பெருசாக இருந்துச்சு. ஸோ அதனால அதுக்குள்ள ட்ரீட்மெண்ட் ஆரம்பிக்கணும்னு நினைச்சிட்டு அப்போ எக்கோ பண்ணி பார்த்தா நார்மல் ஹார்ட்டோட அவங்க ஹார்ட் ஃபங்க்ஷன் ரொம்ப வீக்காக இருந்துச்சு. ஸோ நார்மலாக ஹார்ட் ட்ரக்குன்னு வீக்காக ஆகாது, அதுக்கு ஏதாவது ஒரு காரணம் இருக்கும். அதுக்காக என்னன்றதை ஒரு ஆஞ்சியோகிராம் எடுத்து பார்த்தோம். இந்த ஆஞ்சியோகிராம் எடுக்கிறதுக்கும் என்னன்னு கேட்டிங்கன்னா அவங்க சொன்ன மாதிரி அவங்களுக்கு கிட்னி ஃபங்க்ஷனும் கொஞ்சம் லைட்டாக வீக்காகவும் இருந்துச்சு. ஸோ அதனால நெஃப்ராலஜி டாக்டர்லாம் பிளான் பண்ணி அதுக்கப்புறம் நம்ம வந்து இந்த ஆஞ்சியோகிராம் பண்ணோம். ஆஞ்சியோகிராம் பண்ணும்போது ஆக்சுவலாக அவங்களுக்கு பிளாக்கேஜ் ரொம்ப சிவியராக இருந்துச்சு. ஸோ அந்த பிளாக்கேஜ்னால தான் ஹார்ட் ஃபங்க்ஷனும் கொஞ்சம் வீக்காக இருந்ததுனால ஸோ பைபாஸ் பண்ண வேண்டிய நிலைமை வந்துச்சு. ஸோ இப்போ என்னன்னு கேட்டிங்கன்னா ஆக்சுவலாக பைபாஸும் பண்ணணும், அந்த பெருந்தமணியில் ஸ்டென்ட்டும் வைக்கணும். ஸோ இது ரெண்டும் பண்ண வேண்டிய நிலைமை இருக்குது அவங்களுக்கு. ஸோ இது ரெண்டும் பண்ண ஒரே நேரத்தில் பண்ணுறதா ஒன்றா பண்ணுறதா அப்படின்றதான் கேள்வி. இப்போ வந்து பைபாஸ் பண்ணணும்னு வச்சுக்கோங்க, பெருந்தமணி வெடிக்கிறதுக்கு சாதியங்கள் அதிகம். ஸோ அதனால அதை ஃபஸ்ட்டு பண்ண முடியாது. என்னன்னா சார் காமிச்சாங்க அந்த பலூன் வச்சாலும் அந்த பலூன் மூடி தொடங்கும். அதனால அந்த பெருந்தமணி வேகமாக பண்ணும்போது அது உடையிறதுக்கு அந்த பஸ்ட் ஆகிறதுக்கு சான்சஸ் அதிகம். ஸோ அதனால எப்படி பண்ணுறதுன்னு சொல்லி டிஸ்கஷன் நடந்துச்சு. இப்போ இன்கேஸ் அந்த அயோட்டா ப்ரொசீஜர் ஃபஸ்ட்டு பண்ணணும்னு சொன்னால் ஹார்ட் ப்ரொசீஜர் பண்ணும்போதே ஆஸ்ட் ஆகிறதுக்கு சான்சஸ் அதிகம். ஸோ இதனால வந்து டிஸ்கஷன் பண்ணி பிளான் பண்ணிட்டு என்ன பண்ணணும், ஸோ வித்தவுட் ஹார்ட் லங் மிஷின், அதாவது ஹார்ட்டை சப்போர்ட் பண்ணோம் பீட்டிங் ஹார்ட்லேயே பைபாஸ் சர்ஜரி பண்ணலான்னு சொல்லி பிளான் பண்ணி ஃபர்ஸ்ட் அதை பண்ணோம். அதை முடிச்சு அவங்க சொன்ன மாதிரி 1 month ரிகவரி ஆனதுக்கு அப்புறம் ஸ்டென்டிங் பே பண்ணோம். ஸ்டென்டிங் முடிச்சு 1 வாரம் ஆச்சு. இஸ் டூயிங் குட் நவ.
Over a period of time it may improve because when the heart functions better, number of medications, the kidney derangement due to various factors. When the heart is not functioning properly, the diabetes, or patients taking a lot of drugs. So many medicines are injurious to the kidneys. So when all these systems work well, sometimes the kidney function slowly improves. It will not deteriorate, otherwise it can slowly go back and maybe 3 or 4% of patients may require dialysis. But kidney is now back to normal, not normal, but it is, you can manage without anything. Without anything. Everything we have reduced. Everything we have, so many medicines he was taking. All those, that was the biggest advantage.
நீங்க எவ்வளவு வருஷமா மாத்திரை மெடிசின்ஸ்ல இருக்கீங்க?
பிபி மெடிகேஷன் வந்து இந்த 20 வருஷமா எடுத்துக்கிறேன்.
And now he's not on a single one.
Not even
No BP medication once.
She is checking the BP every 1 hour. I was telling. She told a charge this morning. Taking BP when he is lying down, when he is standing up, when he is walking.
Complex surgery, how many time took, sir?
The bypass surgery takes about 5 hours. This will take Dr. Murali. Come to Murali. Murali can explain about the stent. Olden days,
தான் இருக்கும். அப்போ அந்த ஸ்டென்ட் இருந்தா தான் அது வந்து விரியும். ஸோ அந்த கால் வழியா கொண்டு போயிட்டு அதை அந்த டியூபை வெளியில் எடுக்கும், இந்த ஸ்டென்ட் விரிய ஆரம்பிச்சோம். விரிஞ்சு இட் வில் கவர் த என்டையர் ஏரியா. ஸோ ஒரு டியூப் வந்து நம்ம உள் வழியா பாஸ் பண்ணி ஒரு நியூ டியூப் போடுறோம். ஸோ அந்த இந்த கிராஃப்ல இந்த ஸ்டென்ட் வந்து அட்டாச் ஆயிருக்கு. அப்போ அந்த ஸ்டென்ட் போய் உள்ள விரியும். டிப்ளாய் பண்ணோம். இதுக்கு நம்ம வந்து டை யூஸ் பண்ணுறோம். ஏன்னா இவருக்கு ஆல்ரெடி கிட்னி டேமேஜ் இருக்கிறதுனால நாங்கள் அந்த சிடி வச்சுட்டு எங்கெல்லாம் மெஷர் பண்ணி நார்மலாக இந்த ஸ்டென்ட்டிங் கொடுத்துருவோம். நாங்கள் வந்து ஒரு 100 to 150 ml டை யூஸ் பண்ணுவோம். ஆனால் இவர்